All right, you guys ready? Let's go. The slide, you guys find the slides okay? All right, off we go. It is Wednesday. It is week 8. It is SysPhy. It's the fall of 2022. Oh, and here we have our first duck. We have two birds today. So this is called a bufflehead. Very pretty. The males are very pretty looking. So that was shot down in Elkhorn Slough. So bufflehead. All right, where have we been? So last time we talked about gastrin, and we said gastrin was the major stimulator of hydrochloric acid because it can bind to the parietal cell, which makes hydrochloric acid, and it can bind to the ECL cell, which does the ECL cell make hydrochloric acid? What does it make? Histamine, which is the most powerful driver of hydrochloric acid. Histamine binds to the parietal cell and drives the formation of hydrochloric acid. We said that gastrin is released by just thinking about food, especially if you're going to have a meal you really enjoy. It's interesting, they did some research on this. If you're going to have a meal that you're not really going to enjoy, you don't get a lot of juices flowing. But if you have a meal that you know it's coming, you get a lot more juices flowing by that. Then putting the food in your mouth and chewing it up stimulates the release of acid, or stimulates the release of gastrin. And then, of course, the stimulation of Meissner's plexus, or I could say parasympathetic efferents, or I could say the enteric nervous system. Either all of that stuff, it's really the same, one and the same, just different layers of complexity. But that all causes the release of acetylcholine, or ACH, and gastrin releasing peptide known as GRP from Meissner's plexus. And that goes and does all kinds of things. So here's our one of our little drawings. Let's take a look just to remember this stuff. So I didn't put in a hamburger or chewing up the hamburger, thinking about a juicy cheeseburger, bacon burger. And that stimulates the release of acetylcholine and GRP. They bind to the G cells, which are in pyloric glands, which live in the antral region of the stomach. And that secretes gastrin. Gastrin is a hormone. Gastrin goes in, swims a little bit through the interstitium, jumps in the microcirculation. Now it's off, flowing throughout your entire body. Some of that gastrin actually comes back into the stomach region, and it gets pushed out the proximal capillary, and it's loose in the interstitium again. And some of it comes and stimulates these guys right here, the parietal cells, directly to release hydrogen. We'll just call it acid. Remember, those are CCK2 receptors that gastrin binds to. Everywhere gastrin binds to CCK2 receptors. That's a direct route. It also goes over and binds to ECL cells and binds to CCK2 receptors again. And that doesn't shoot anything into the lumen here of this oxyntic gland, but instead it causes histamine to be released into the interstitium, into the out the basilateral surface, into the interstitium, and that's going to swim, and it's going to bind also to parietal cells. It has receptors for parietal cells, CCK, or that has H2 receptors, and that we said is the most powerful stimulator of acid out of all of those agonists. Histamine is the most powerful. It's more powerful than acetylcholine and gastrin. So another mechanism, more hydrochloric acid being released into the lumen of this oxyntic gland. And we're not even done yet. So then gastrin is going to, for our purposes, we're going to say it does, because most of the research says it does bind to CCK2 receptors on chief cells. We're a little bit shaky on that. There's some papers that say it doesn't, but most say it does. And that causes the release of pepsinogen, just call it PEP, which is immediately going to be broken down when it comes into contact with hydrogen ion into pepsin, which is a powerful proteolytic enzyme. And then we have another effect of gastrin. So if we follow this pathway, now this one only works when there's tons of gastrin floating around in the bloodstream. But if there's high levels of gastrin, it can go bind to these oxyntic D cells and wake them up from their sleep. And when they wake up, they secrete somatostatin. Somatostatin shuts all of this stuff down, or it tries to shut all of this stuff down. Okay. So that's pretty much the story with gastrin. So make sure, I know it's a complicated story, but it is on boards. You're going to get it again when you get to GI, phys, and pathology. I just talked to my roommate about that, and you will get it again. So it's not going away. Okay, we talked about how to shut off acid. I kind of just said a little bit, it's somatostatin, but it's mainly gastric acid secretion is mainly regulated by a hormone, acts as a paracrine as well, called somatostatin. We said somatostatin is produced by D cells. We don't call them delta cells. What are delta cells reserved for? Pancreas. There's delta cells. That keeps that name. So these are just D cells. And we said there's two different flavors of D cells that live in the oxyntic glands and the pyloric glands. So here's the oxyntic gland that live in the fundic region of the stomach. And there they are hanging out. And there's the other flavor of them over in the pyloric region of the stomach. And remember, these are the ones that taste hydrogen ion. Remember the ones in the oxyntic gland, they're the ones that respond to gastrin. We actually just talked about those. Okay, they do not taste. They have no receptors to taste hydrogen ion here. Only the pyloric ones have receptors that taste the fluid here in the lumen of this gland. And they taste how much hydrogen ion. In other words, they taste the fluid to see how acidic it's getting. And when it gets to about 3.5, this cell wakes up and it starts shutting all of the acid producing machinery down. It can't do it immediately. These aren't super powerful mechanisms, but it starts to slow the wheels down. Okay, so here's just everything pretty much I said. Let's take a look at the antral somatostatin. So that is, there's an antral D cell. Okay, that's in the pyloric region of the stomach. It's tasting. It's got a little snake tongue tasting the fluid. And once there's enough hydrogen ions, meaning once the pH is low enough, it wakes up and it does some stuff. This one's interesting because it's both this somatostatin acts as a hormone and as a paracrine. So the first thing it does, it swims over not very far away from it, and it binds to G cells. We're not going to worry about the receptors, but it binds to G cells and starts slowing them down. So it slows the release of gastrin because we've already gotten to a pretty acidic condition in the stomach. It's time to start putting the brakes on that. So it's done there by binding to gastrin. The hormone flavor of it goes throughout the body, and that takes it all the way over into the fundic region of the stomach, where it gets out and it binds directly to parietal cells and starts to slow it down, slow those down as well. It doesn't completely shut off hydrogen ion, but it starts to slow it down. Also binds directly to ECL cells and starts slowing the production of histamine down. So those are the main actions here, all stimulated by tons of hydrogen ion around, by a pH that's getting below 3.5, which is pretty darn acidic. Stomach will get down to 2, about 2, because we're putting the brakes on this, but you don't want the stomach acid to get down to like 1. You'll start going right through that protective mucus barrier, the gastric mucosal barrier that we talked about. Okay. This is also shut down by acetylcholine when you're starting your meal, because we don't want any somatostatin around when you're starting a meal because we need that acid. So one of the jobs of acetylcholine is to bind to both of these cells and shut those down to make sure we're not secreting somatostatin. Okay. Let's see. Now the oxentic somatostatin is over here. We kind of talked about that already. That is the one that is stimulated by gastrin. So once we get way high in we won't worry about the exact number, but once gastrin levels are very high, then this wakes up and it binds to ECL cells and it binds to parietal cells and shuts both of those things down. The difference in this is there is no hormone involved here. The oxentic somatostatin does not have any hormone action. It can't travel all the way over here and bind to G cells. Okay, so that's the difference between. So that's a good note card, a good testing question. So antral D cells, their somatostatin acts as a hormone and paracrine, while oxentic D cells, that somatostatin only acts as a paracrine. Okay. We also said it's stimulated. These are the ones that are stimulated by catecholamines as well, because if you're running from a tiger or you got some big stress event coming up, we need all the blood to go to the brain and to the muscles. We don't need this machinery running. If this machinery is running, you're going to be opening capillaries, more capillaries in the stomach. It's going to be stealing blood away from the core. So we don't want that. All right. Question.
So the oxygen B cells is catecholamines, and what else is stimulated?
Just catecholamines.
Okay.
Yeah. And of course, gastrin. Yeah. Elevated levels of gastrin. That's the main one. Catecholamines is just kind of a fun fact thing. About the antral somatostatin. Antral somatostatin's right here. So that one acts as a paracrine, which means it doesn't go into the bloodstream, and it acts as a hormone. So the antral somatostatin can go all the way over to a different part of the stomach and shut off parietal cells and ECL cells. That's not true with oxentic D cell somatostatin. That can't travel back. It'd be nice if it could go back here and shut down the G cells, but it can't. And why the committee designed it like that, no idea. Kind of a mystery. We'll probably discover it someday. There's got to be a reason, though. Are we good? Good as possible? Stuff starting to sink in. This is very complex stuff, I know. I'm confident that you will get it down. We looked at this, another complicated, that was a complicated lecture last time, wasn't it? We looked at this a little bit. We're not going to go insane on this inflammatory pathway. I'm sure you're going to be getting this more when you get into more biochemistry. But you should know this story at least, that when you sprain your ankle or when you injure tissue or you get hit with a baseball in the chest, whatever damages tissue, tissue is all made of cells. And all cells have a phospholipid bilayer. So when you get physical damage, the cells are broken and exploded, and you release some of those phospholipids into the substance, into the interstitium that tissue sits in. And there's an enzyme sitting right there waiting for it. And that's called phospholipase A2. That is the start of the inflammatory cascade right there. And by the way, side note, steroids like prednisone, those super high-powered steroids, they actually block the action of phospholipase A2, and that's why they're the best steroids for fighting inflammation. But they have a lot of deleterious effects, so you never want to just take prednisone when you always start out taking, assuming conservative care. Most of the time, you don't even need anything. Conservative care can take care of it. And most of the time, you don't even need conservative care. The body will just heal stuff. You guys know that. Everybody's had a little sprain here and there. You didn't go off to the doctor and get 6 months of treatment for it. It just got better. The body can do most of this stuff by itself. But as you get older, your body loses the ability and the inflammation hangs around too longer. So a lot of the people you're going to treat are people my age and even older. Question.
Well, then there's some prednisone, like prednisone, in people, for instance, on others,
on young and old people, the effects are just like Cushing syndrome. Prednisone is just cortisol, really. So it's hypercortisolism and all of its negative sequelae. You can start to get the moon face. I don't know if you've had any endocrinology yet, but Cushing's, people who have too much cortisol in them, same as too much prednisone, they start getting kind of a round moon face, it's called. They get a little buffalo hump going back there. They start getting red cheeks called facial plethora. In males, it likes to destroy the muscles of the quads and of the arms. So you get really skinny arms, and it deposits fat around your abdomen, especially in guys. So you get kind of the Homer Simpson belly. And this is not like a 3-month course of prednisone. This is people who have to be on it. They have rheumatoid arthritis. For the bones, it destroys bones. So you get osteoporosis the longer you're on them.
Long-term,
Not cancerous or anything, but it's really bad for bone health. It also raises your blood pressure. Hypercortisolism stimulates the receptors for norepinephrine and makes the arterioles very contractible. When the arterioles contract, it shoots blood pressure up. So people always raises blood pressure. So that can wear out the heart in the very long term. So that's like some of the very long-term sequelae of it. Yeah. A 10-day course when you get older, maybe you have back pain, you try conservative care. It just doesn't work. You've tried NSAIDs, Advil, Nuprin, all the usual stuff. It just doesn't work. You finally have to go to your family doc and they'll give you maybe a course of prednisone. There's something called a Medrol pack that works really good where they bomb you. It's about a 10-day course where you ramp up, and that's important to ramp down, because when you ramp up and take cortisol, it shuts off your pituitary gland, shuts off your adrenal gland, and that's another effect of taking prednisone long term. Some people, when they can't come off it because their machinery just never comes back on. So there's a lot of you want to use that one really sparingly. Very good question. All right, so we made our phospholipase A2 made arachidonic acid. We said that's very unstable. It doesn't like to stay around long, so it hooks up with COX-1 and COX-2 and creates another unstable molecule called prostaglandin prostaglandin H2, abbreviated PGH2. I left out an intermediate step, but that's not important. Another unstable molecule. And this one can go 3 different ways. It can go to form PGE2, which is the inflammatory pathway. It causes pain at the injury site. It can cause fever, and it causes inflammation is the big one. And this is the cycle right here. PGE2 really likes to convert into several different molecules which stimulate inflammation, or PGE2 stimulates inflammation too. And that's the one we need to get rid of sometimes. But what people forget about is some of this PGH2 splits into thromboxane A2. And I'm not testing you on this part right now, but some of it split into thromboxane A2. Some of it morphs into prostacyclin. And normally there should be a very nice balance between coagulation of blood versus anticoagulation of blood. And the danger with this, with COX-2 inhibitors like Celebrex, and another one got pulled off the market for this very reason, called Vioxx, which was one of my favorite anti-inflammatories until people started dying from heart attacks and strokes and stuff, older people. But the problem is this, that COX-2 is the only enzyme that makes prostacyclin. So COX-2 inhibitors, they block this pathway. So PGH2 no longer goes this way. So what's going to happen to all the buildup of PGH2? Like if this is a car accident and the road's completely blocked, well, you got to turn around and go back this way. So it goes this way and it goes to inflammation, but it goes to the coagulation cascade. So you form more thromboxane A2 and people get blood clots like crazy. You get a blood clot in the heart, you can have a heart attack. Get a blood clot in the brain, you're going to have a stroke. And that's the problem with Vioxx. Was so darn good. at knocking out inflammation, but it was also very good at knocking out prostacyclin. And it really drove this hard to form thromboxane A2 when people were just getting blood clots and heart attacks and strokes way, way too much. And so they banned it. It's still available in some countries, but I think in Mexico you can still get it, but it's not. Don't ever want to mess with that one. So anyway, without the coagulation, anticoagulation, you should definitely know that phospholipids from blown up cells of the injury site are grabbed by phospholipase A2, morphed into arachidonic acid, which is morphed into by COX-1 and COX-2, PGH2. PGH2 goes this way and form PGE2, which causes pain, causes inflammation. And that's also the one that creates the gastric mucosa barrier. That's how we got off on this rabbit hole, right? We learned that PGE2 is responsible for making mucose cells create mucus or mucin, which is converted into mucus, and bicarbonate, and that's the gastric mucosa barrier. So that's the other trouble. That's the trouble with the over-the-counter COX-1 inhibitors, that you block COX-1 here, and then you're going to lose your gastric mucosa barrier. So we said that it's pretty common for, again, older people who've been on Advil for a long time or Aleve for a long time to develop ulcers because of this, because they're blocking COX-1 and they're blocking intestinal PGE2 from doing its job. So that's kind of a good little review of all that stuff. Are we good with that as possible? Question?
So the good X is just mean that it blocks that and go for the back.
Yes. An X means that COX-1 inhibitor has blocked it. Question?
Does COX-1 also block PGE2? So that's why it's
COX-1 blocks PGE2. Intestinal, it blocks all PGE2. Yeah, but especially the intestinal PGE2, because the COX-1 enzyme makes PGE2. Remember, PGE2 turns around and stimulates itself and its neighbor to produce bicarbonate and mucin. So that's a very important molecule that we all have this one going on all the time. The trouble is PGE2 is everywhere. It's in every tissue in your body has it, has these COX enzymes that can make it. So are we good? Good as possible? Okay. All right, and here is PGE2, kind of said all this, but remember our intestinal PGE2 is released from mucus cells. It's created by the enzyme COX-1 that lives in there. We said COX-2 is in mucose cells too, but it's usually turned off and it doesn't activate. And the PGE2 comes out the basolateral surface. It binds to itself, it binds to its neighbors, and it stimulates the release of mucin and bicarbonate. And it is so important for keeping this mucousy basic barrier that coats the stomach so our acid doesn't rip up our stomach. So very important thing. Let's see. Oh, okay, I put this in. So here's a little cartoon of the same thing. So these are mucose cells, and mucose cells have COX-1 enzyme in them. And this is an oxyntic gland, but the fundate glands are the same deal, or the pyloric glands are the same. They all have mucose cells. The whole stomach is lined with these mucus cells. They all release PGE2. PGE2 turns around, self-stimulates itself, and then it stimulates its near neighbors. What does the stimulation do? It causes them to produce bicarbonate and mucin, and it mixes with water, and you basically have a cloud floating over your inner lining of your stomach, which protects your stomach from acid, which is a good thing because the acid would digest your stomach just like it does a piece of steak. So that's a very important mechanism. And that's called the gastric mucosal barrier. We also said PGE2, it can swim paracrine style over, and it can bind to ECL cells and shut off the production of histamine as well. So the thing you have to know is, like here, like a question would be, can PGE2 bind to parietal cells and shut them down? No, doesn't do that. Can it bind to chief cells and shut down pepsinogen? No, it only one it binds to is the ECL cells, the enterochromaffin-like cells. Those are the ones that secrete histamine. Okay, so make sure, make a note card and get that one in your noodles. All right, and then the question came up. I got an email question. Why does it shut down the production of histamine when you're eating food and stuff like that? Well, it's not super powerful, and it does try to. But the idea is you want to slow down the production of acid and not let the acid get out of hand. So that's why it tries to fortify the gastric mucosal barrier. Gastric mucosal barrier gets beat up if a lot of acid is secreted. So it tries to slow down the secretion of acid, but it's not a super powerful mechanism. The other mechanisms override it, but it tries. Let's see, everything I just said there. Binds to ECLs, inhibits the release of histamine, and therefore PGE2 indirectly decreases the release of hydrochloric acid, or at least tries to slow it down. It doesn't bind to parietal cells, so it can't directly inhibit it, but it binds to ECL cells. Those release histamine. So if it slows down the release of histamine, it's kind of indirectly lowering the secretion rate of acid. Okay, so now that we're through that dreaded stuff, we might as well talk about a condition, and it's called ZE syndrome. Who's heard of Zollinger-Ellison syndrome? Nobody's heard of this. Let's talk about making some sense. Why do we have to learn all this stuff? Because you might have a patient with Zollinger-Ellison syndrome. It's more common than Marfan syndrome. It's fairly rare, though. Maybe a couple times over your career, you'll see this. It's also called ZE syndrome or Gastronome. I'm going to call it Zollinger-Ellison syndrome, like the board books do. And it's a condition that causes the way overproduction of acid all the time. You eat a hamburger, hamburger's gone in 6 hours. Normally your acid production, all the mechanisms shut off your acid, right? Not in these patients. The acid is flowing all the time. Why in the world is this happening? What is driving acid and pepsinogen to be produced all the time? Turns out it's a tumor, usually in the pancreas. And it's a neuroendocrine tumor, meaning it's going to secrete some type of hormone or some type of paracrine. And in this case, this tumor is made of G cells. It's made of mutated G cells, though. They're not your normal G cells, as we'll see in a second. But G cells still do what G cells do. They secrete gastrin. So we have an ectopic foci, if you will, that is secreting gastrin. So gastrin is secreted ectopically. When you see the word ectopic, it means that you have some type of cell or gland that is secreting the normal stuff it's supposed to secrete, but it's not in the right place. It may be way away from where it's supposed to be. And in this case, it's usually in the pancreas. G cells are supposed to be in the oxentic region of the or in the fundic or in the pyloric-antral region of the stomach, the antral region. It's not supposed to be in the pancreas. Why would you have G cells in the pancreas? Well, you're not supposed to. And sometimes these are cancerous too, by the way. They didn't put this one in here. We got save something for Dr. Fernando to talk about. But they can be cancerous. A lot of these neuroendocrine tumors are. So yeah, that is the story. So we have a mutated bunch of G cells hanging out in the pancreas, and these G cells secrete gastrin like crazy. But the problem is they just do it all the time. they don't have any receptors for somatostatin, so you can't shut them down. That's the problem. And they don't even have any acetylcholine receptors or GRP receptors. They don't need it. They just are turned on all the time. They're mutated cells stuck in the on position, and it's blasting gastrin out, and you have very high levels of gastrin all the time. And that's not a good thing. That's not the gastrin that causes the trouble. Gastrin binds to, like usual, it binds to the parietal cells and it drives the release of acid, binds to ECL cells. They're in overdrive producing histamine. Histamine binds the parietal cells, drives the formation of acid. So you got all these cells on all the time. They're never resting. That's a recipe for cancer. What's that? You got it. Yep. I got a slide coming on the sequelae of it, but you got it. You're going to have tons of acid in your stomach. It's going to rip your stomach. It's going to rip your duodenum up as well, right? Because you're going to have the Brunner's glands can't produce enough bicarbonate to neutralize the acid. So you got problems. Question.
Body's still producing somatostatin, but it doesn't have receptors.
Yep, producing it like crazy, but it's the one that, remember the somatostatin in the antral region or in the fundic region. Those are the ones that are turned on by gastrin. So those guys are on all the time, but I said that's not a very powerful mechanism. It's just not enough to even put a dent in gastrin. Up against gastrin is way more powerful than somatostatin. Say good questions. All right, so what's the deal? So that G cell is made up, creates a tumor of mutated G cells constantly on. And you could, maybe you have maybe you have a tumor of gastrin secreting cells and they're mutated in such a way that they don't work. That's possible as well, and you don't even know you have it. So this type of tumor happens to be the G cells are active. So you can have all different types of mutations. But this one, gastrin is just secreted all the time and nothing can affect it. There's no receptors for somatostatin, so you can't turn it off. And this scenario results in very high serum levels. You see that? What's that mean? Serum levels of gastrin. That's your blood. Yeah, that's where it lives in the watery. Serum is the watery part. It's not in the cells of the blood. It's in the watery part of the blood. And so you can test this. You can test for levels of gastrin, and they can catch it with a blood test. The tumor, we said, it's almost always in the pancreas. That's why sometimes it's called a pancreatic gastronoma. Pancreatic gastrinomas cause ZE syndrome. It's not always there, though. About 10% of the time, it's actually in the glands, the crypts of Lieberkühn, which we'll probably get to next time I got to start the heart here pretty soon. But do you know crypts of Lieberkühn? Does that sound familiar from somewhere? No? Did you have that in histology? Should have had that in histology, maybe in cell phys. The crypts of Lieberkühn are really important. Dr. Fernando will have to take that one probably. But they're important. They're important. They're kind of like fundic glands or like accentic glands. They secrete a lot of the juices that are needed for digestion. Maybe we better put that in on Monday. That's important. But anyway, you can have some of these tumors can be growing in the crypts of Lieberkühn in the duodenum. About 10% of the time, it's not in the pancreas. Probably 95% of the time, it's in the pancreas, or 89% of the time, it's in the pancreas. 10% of the time, it's in the duodenum. 1% of the time, it could be in your big toe, could be in your eye, could be in your appendix, could be anywhere. You can get ectopia anywhere in the body. Now, the sequelae. So what's the result of all this? Some of you are already figured this out, but if you got tons and tons of gastrin, you're going to be driving parietal cells like crazy to release hydrochloric acid. You're going to be driving chief cells to release pepsin. You're going to be, the ECL cells are going to be driven like crazy to make histamine. What's going to happen to these cells if they're working all the time without a break? What happens to bodybuilders who work out all the time? They take steroids so they can work out all the time. Steroids don't make your muscles big. You know that, right? Steroids allow you to work out. Like you and I would go into the gym and work out and would be sore for 3 or 4 days. They'd be ready to go in 6 hours. The steroids speed up recovery, allow you to work out harder. But what's going to happen to these cells if they're working out all the time? They're going to get big. They're going to hypertrophy, and they can get so big that you can go in to look at the stomach with an endoscope, and you got these gigantic rugae. We'll even take a look at that here in a second. But yeah, they stimulate and drive all these cells. These cells are going to start to get big because of that. And yep, here's this gastronome I threw in there last night. So there's a gastronome secreting gastrin, and we already know what it does. Binds to parietal cells, binds to chief cells, binds to ECL cells. All of that stuff drives the formation of acid. It also, side note, it also drives the oxentic D cells to secrete oxentic somatostatin, which is also high, but it's just such a weak mechanism compared to all this other stuff. It really doesn't make a dent in the acid production. Right, so oxentic D cells are activated, but the mechanism's not strong enough to overcome. The gastrin's just too powerful for this. All right, we all good with that? Good as possible? Nope, they're not driven by gastrin. Yeah, they're driven by, well, you know what? They would be though, wouldn't they? Yeah, these guys are on too, because your stomach acid is going to be like 2 all the time. So come to think of it, yeah, they'll be on as well. They're not driven by the gastrin itself, but if your stomach is always acidic, these will be on as well, trying to shut everything down. But again, they're just not, somatostatin just is no match for gastrin. Gastrin and histamine, the same thing. It's just, those are too strong of drivers of acid for this to affect. But that's a good point. Both antral and oxentic D cells are activated. Question? The what?
Cells get abnormally large.
All of these that are driven and on all the time. The main ones are parietal cells, ECL cells, and these guys are just driven all the time. G cells, no, because they're not the ones causing, they're not even working properly, they're off. Somatostatin might slow them down a little bit. But all parietal cells, ECL cells, and both of these D cells are going to be hypertrophic, and there's going to be too many of them too. The body's going to think, well, you guys aren't doing your job, we better make more of you. So, all right, so more sequelae. Then what's the clinical sequelae of this? Well, if you have too much acid all the time, of course, there's a name for that, and that's called hyperchlorhydria. Hyperchlorhydria. So people with ZE syndrome have hyperchlorhydria. And what's the sequelae of hyperchlorhydria? People who are stressed out all the time. Some people, the stress can cause the release of acetylcholine, and they can have hyperchlorhydria and get ulcers, worrywart type people. But hyperchlorhydria, no matter where it comes from, you're going to have GERD, because we all burp up a little bit. Most of the time we burp up way after a meal and it's not very acidic, no big deal. But if your pH is always 2 in your stomach juices and you burp up pH 2, that's going to rip your esophagus up really easy. And then, of course, if you have GERD all the time, it increases the risk for Barrett's esophagus. And if you have a Barrett's esophagus, you're at risk for that deadly esophageal carcinoma. So you're also going to have upset tummy all the time. So you're going to have gastropathy or gastritis or dyspepsia. The symptom would be dyspepsia, means upset tummy all the time. That's not like a couple of days you went out partying, your stomach's upset for a few days. That's not. Dyspepsia is, it's going on for months and months and months, 3 months, 4 months, 6 months if you had an upset stomach. That's dyspepsia. And then another sequelae of the acid is PUD, peptic ulcer disease, right? Your gastric mucosa barrier can only do so much. It can't overcome a pH 2 24 hours a day, and you'll start punching holes in the stomach. And even more common, the stomach will be ejecting too acidic a chyme out of it, and it'll burn holes in the intestine as well. And sometimes in really weird places, all intestinal ulcers, probably 99% of intestinal ulcers are in the duodenum, usually in the duodenal bulb, the very first part, because that's where the acid comes up. You hardly ever see problems in the jejunum or ileum. In ZE people, you can see ulcers in the all the way down to the ileum or in the jejunum, which is tough to check out, by the way, because we don't have a scope that goes all the way through the small intestines. When you get your GERD checked, the endoscope can go in your stomach, and it can go in the first 2, maybe 3 parts of the duodenum. That's it. So how do we see cancer and things like that in the jejunum and ileum? You have to swallow a little camera pill, which has got like 10 little cameras pointing all directions, and you just keep your fingers crossed that you got lucky and it spotted that cancer, you spotted that ulcer. And it's about 75% effective. It's not the greatest, because you got all that film to watch, and then you have to have a technician watching the film. Maybe it's on Friday and they're watching YouTube videos and watching the film. And yeah, it's just not the greatest technology. And I'm sure that doesn't happen. Yeah, right. I'm sure it does happen. Diarrhea. ZE people have diarrhea. People stressed out all the time can get diarrhea. What's the deal? Anybody know that mechanism? So it's going to kind of lead us into our next topic. We're going to talk about enterocytes, and we start talking about the small intestines. The intestines are all lined with an endothelium, which is made up of simple columnar cells. They're really good at absorbing water, especially your small intestine. It absorbs most of the water that you drink, and we need that water. But if that acid if it gets too acidic, those enterocytes get upset. And remember I said sometimes when cells get upset, they can either over-secrete something or they quit and don't secrete anything. This is a case of they quit. And they stop, they get inflamed, and they say, I'm not going to work. I'm not going to absorb water today. We're shutting down. And so where's that water go? Goes right into the toilet, mixed in with your fecal material, and you get a combination of really loose fecal material with water, and that's diarrhea. So they do get diarrhea. So there's the bodybuilder. So what's the histological appearance of these patients? And you'd have to look at a biopsy. A pathologist would see this. But the parietal cells, chief cells, actually all the D cells, we can add fundic as well as accentic D cells, and the ECL cells, they all become like this bodybuilder, like way too big. So they become, and what's the word for that? It's called hypertrophic, become hypertrophic. And there's too many of them as well. They tend to proliferate. Hypertrophic cells tend to divide too fast. So you start getting too many of them as well. The pathologist can see that. I have a picture of that coming up. Common patient symptoms. Again, this is a study that was quoted several times in Schlesinger, which is a GI pathology book. So about 75% of the time, people with ZE syndrome, they have dyspepsia, upset tummy. 75% of the time, diarrhea. 70% of the time, this is the big one, they have peptic ulcers. It's a very common cause of peptic ulcer disease. And 44% of the time in this study, they had heartburn. So all the stories we talked about. Who knows what this word is? Streatorea. Streatorea. I always learned at steatorrhea, but Streatorea. Ready for a gross picture? Now, if you're sensitive, close your eyes. Close your eyes. Oh, that's, you probably never seen anything like that come out your bottom end. That's steatorrhea. So what is the deal with that? So the acid, we'll take a break right after this. So the acid, it also deactivates pancreatic lipase. The pancreas is okay in this condition, The acid isn't going up inside the pancreas. The pancreas is still making pancreatic lipase, which normally breaks down fat. We're going to maybe look at that if we get time this time. But it deactivates pancreatic lipase. So there's no pancreatic lipase. So you can't break down fat. So your fat goes right on through, unbroken down, and that's what fat looks like that hasn't been broken down. Steatorea. Fatty stool. Let's see, where can we break? Now let's break right here. Let's take a lap or two, relax a little, think about this stuff, and come back. Finish this off. So 5 classic diagnostic findings in people with ZE syndrome. So hypergastrinemia, so you do a blood test and you find high levels of gastrin. Hyperchlorhydria, how do you diagnose that? You have to stick a scope down in the stomach and pump a little of that stomach fluid out and analyze it. So it'll be like pH 1, really crazy acidic. You treat somebody for peptic ulcer disease and they don't get better, just keeps going. That means refractory to treatment. That's a good vocabulary word, refractory. The patient was refractory to acupuncture, meaning it didn't work. They're resistant to it working. So they have refractory peptic ulcer disease, meaning they've tried PPIs to get rid of it. They just can't get rid of it. And then back on endoscopic exam, the rugae look really, really big. And you get in there and look closer, it's because they have hyperplasia of all the main players. Parietal cells, ECL cells, chief cells are just working too much, and D cells would be hyperplastic as well. And then they have diarrhea all the time. So classic symptoms. Definitely good, easy for me to make a question out of that slide. Endoscopic appearance, we already said, they're going to have hyperplastic looking rugae. The rugae, and this is going to be years down the road. It's not going to be immediately. But the rugae are going to be huge because the cells and glands are underneath are huge because they're always turned on. And it's a scary finding when a GI doc sees giant rugae because it can look like lymphoma. Cancer does the same type of thing. It drives these cells. The only difference is they become cancerous, but it can look similar. Another one called Mentier's disease, and we won't get into that. It's pretty rare. So here is a endoscopic view of a normal stomach. And remember when the stomach is completely empty, the rugae are much bigger. As the stomach stretches and stretches, the rugae gets smaller and smaller and smaller. Not true of the intestine, by the way. But this is a normal looking, and those are pretty big looking rugae. And here is someone with ZE syndrome, kind of blown up, and they're just gigantic. So you can't miss it. And again, the trouble is Hodgkin's and some of the lymphomas can look similar to this. So you have to do further workup if you see this. But usually you just do some blood work and you catch all the gastrin, and it's a gastronoma. The question is, where is it? Because sometimes it's as big as a pea. And have you seen the pancreas in anatomy yet? Or not yet? Pancreas is not a very impressive looking structure. Your expectations will be dashed when you see it. It's just kind of a dried up piece of beef jerky kind of. But the tumor can be the size of a pea. And so finding the tumor can be problematic. And you have to see high levels of gastrin. Some of these, what is it, about 15% of them are cancerous. And the cancer can metastasize and kill you. So you got to work this up. And the treatment is, at first, maybe it's a tiny little tumor and it's not secreting that much gastrin. You can handle it just by turning off the acid in your stomach. So PPIs and H2 blockers and all the rules, just treat it like you would GERD. Don't eat before you go to sleep. If you have all that acid in your stomach, it's going to go bubbling up into the esophagus pretty easily. And then finding the tumor, oftentimes you have to do something called a PET scan, which most of the big hospitals around here have. But if you're out in Nebraska somewhere, a little town in Nebraska, they probably don't have one of those scanners. Those are much more accurate than CT or MRI. Bone scan or scintigraphy can also be used. So you got to hunt down that tumor. And is it in a place where you can do surgery? If it's in the neck of the pancreas, you can't really do surgery on it because you'll destroy the pancreas that way. Pancreas is so delicate. If it's up in the brain, you probably can't. It's better just to treat it with proton pump inhibitors and all the anti-acid stuff, and keep an eye to make sure you're not getting Barrett's esophagus. So it can be difficult to treat. If it's in the tail of the pancreas or in the body and it's toward the surface, you could probably take it out and patient will be really happy, very successful surgery. But it all depends if you can find it in the first place. If you can find it, where is it located? One slide on intrinsic factor. We haven't talked a lot about that. When you'll have a nutrition class. Actually, we are I think I threw these slides in. Intrinsic factor is really important, heavily hit on boards, because intrinsic factor deficiency leads to vitamin B12 deficiency, and that can present with sciatic-like symptoms or radicular pain. Those people will come into your office. Probably had half a dozen of them over my chiropractic 20-some year chiropractic career. They do come in. And remember, intrinsic factor is secreted by parietal cells. Kind of gets overshadowed by acid production, but it also gets, it's not made, it's a different mechanism. It's not made by the proton pump. It's a different mechanism we won't get into. Remember, it's part of the hipster. It's the I in the hipster, hydrochloric acid, intrinsic factor, and pepsinogen. That's the stuff that comes out of the fundus gland, aka accentic gland. Its job is to hook up with B12. Vitamin B12 is very delicate. It needs a chaperone at all time as it travels through the tubes. The first chaperone is something called food binding protein, and that's bound. It comes with it when you chew up a piece of meat that has high in vitamin B12, a piece of liver maybe. That B12 is not floating free. It's always bound to proteins. We just call them food binding proteins. And then heptocorin takes it. I got a slide on this. And then intrinsic factor takes it to the final stretch. It's like a relay race. Intrinsic factor is the last leg of the relay. It takes it on home. And we said it binds to the distal ileum, to those weird CBAM receptors or those cubular receptors. Question?
Was that ribosomes or nucleic acid?
What was that?
HIP, the P stands for.
That is pepsinogen. Pepsinogen. Hipster. I thought I put that story in. Maybe I took it out at the last minute. All right, we are starting the small intestine. Yay. Not nearly as complicated as the esophagus, thank goodness. So pretty straightforward, I think. It is about 5 meters long. It's quite variable from maybe 2 to 7 meters. It's really long if you string it all out. It's the small, known as the, what's the AKA for it? Small bowel. Sometimes it's called small bowel is the AKA for it. And it's all coiled up inside the peritoneal cavity. Inside the peritoneal cavity, all of the small intestine lives except for who? Most of the duodenum, most of that is extraperitoneal except for the duodenal bulb. So most of it is inside the peritoneal cavity. All the jejunum, all of the ileum live inside the peritoneal cavity. And it has 3 distinct regions we probably know. The duodenum, however you want to say it. That one is mostly, again, extraperitoneal. I guarantee I'm going to be testing you to see if you remember that. What organs are inside the peritoneal cavity? What organs are outside? I just showed, let's see, we just had that lab where I got to show the students the peritoneal cavity. So you'll get that. I think it was Reg 3. So I think you get that in 2 quarters. But anyway, you'll be able to see it with your own eyes. The jejunum and ileum, those are intraperitoneal. Those are more dangerous if you get a hole, right? If you get an ulcer down there, it's more dangerous because we said anything inside the abdominal cavity can jump into the blood. The infection can jump into the blood really quick. and cause peritonitis, which can morph into septicemia really quickly. Histologically speaking, very similar, these segments, so I'm just going to kind of talk about them in general. The plicae circularis, the folds are like rugae type things in the intestine, are called plicae circularis. They're not very prevalent in the duodenum. They're crazy prevalent in the jejunum and like medium prevalent in the ileum. And other than that, there's some slight differences here and there we'll kind of take a peek at, depending how far we go in this. Like I said, I got to switch over to the heart here pretty soon. What does it do? The small intestine is the place where most of the food, most of the water, most of the minerals, nutrients, that's where most of the absorption occurs. In fact, most of it occurs in the duodenum, the very first part. Jejunum helps out, and the ileum has a pretty easy life. It doesn't do much except reabsorb vitamin B12 as it's claimed to fame. And it's not that there's something wrong with it, because the histology we're going to go through is the same on all regions. It's that the duodenum and jejunum are so good at absorbing food, there's nothing left. By the time the food makes it all the way down to the ileum, it's all digested. And so the ileum doesn't have to do so much work. So pretty good to be in ileum sometimes. But it could, if you get cancer and they have to take out a chunk of your jejunum, then the ileum can step up and fulfill that. You won't even miss a step with regard to absorption. Another thing we should know about the ileum and the absorption of nutrients. It absorbs food indiscriminately. What does that mean? Indiscriminately. That means what you put in your mouth is going to be reabsorbed. If you eat 10,000 calorie lunch, you will absorb all of those 10,000 calories. Back in the day when I went to school, they thought you didn't reabsorb more than about 3,500 calories. The rest of that food went wasted right through your system. You didn't get fat like that. That is absolutely not true. Everything you put in your mouth will be absorbed. The intestines are very good at doing that. So that's indiscriminate absorption. So if you're on a diet, keep that in mind. You don't want to eat 5,000 calories per meal. It's better to have 5 or 6 meals and have little bitty meals instead. If you eat 10,000 calories, your body will utilize maybe 2,000. What happens to the rest of those calories? That's right, stored right in the old gut. Body's very good at making fat, which is good, because if all the supermarkets close and we run out of food, you can live on your fat. There's some consequences to that. But if you ever watch that, what is that show I'm watching? Alone, the Survivor show. The people who got a little beef on them always do better than the people who are really lean, because if the lean people don't get food or fish, they're gone. You can live on your muscles, but is that a good thing to rip apart your muscles to make glucose? That's a terrible thing for your heart. It'll wreck your heart or wreck your liver and such. So good to have a little extra meat on you, maybe if you're in a survival situation. There's a couple of exceptions. Iron and calcium, your body will reject them. If you take calcium pills and iron pills, don't take more than the recommended allowance, because the rest of that will go right in the toilet. Vitamin B12, we said, that's an exception, the water-soluble vitamin. That one's actually stored in the body, but not iron and not calcium. There's probably some other little ones too. You'll get more of that in nutrition. But so indiscriminate absorption. This small intestine is amazingly tough organ. If you lost 50% of the intestine from cancer, you would have no loss of function, no dent in your ability to reabsorb food. The ileum would kick on and you would be good. So, and we'll see why that is. You might know why that is, but the epithelial lining of the stomach is crazily folded, basically into three parts that we haven't seen that in the esophagus. And the stomach, the endothelium is straight. just parallels, it follows the tube, plane of the tube. That's not true right now. The stomach has the rugae, so there's a little more surface area, but it's going to get crazy here in a second. We'll look at these folds. And the folds, you might as well put these on a note card. Plicae circularis is the most basic level. Then we have the intestinal villi, and then we have the microvilli. So there's really 3 different folding systems that give you a huge surface area. I don't know what happened to this slide. Oh, that was the vitamin B12. Oh, there it is. Now, how in the heck did I do that? I did something fancy. I had no idea I did that. Anyway, I thought you guys lucked out, but you didn't luck out. So now there's one exception to that rule, that distal ileum is really important for 2 things. We already talked about it. We're going to really talk about it in a second. Vitamin B12, because that's where the cubolin or the kabam receptors, the old Batman movies really go kabam. Kabam receptors absorb vitamin B12 intrinsic factor complex. So you can't lose the distal ileum, and or else you'll become deficient in B12. And you will learn that a very famous disease called Crohn's disease, everybody's heard of Crohn's disease, right? Guess what Crohn's disease, its favorite target? Distal ileum. So Crohn's disease patients oftentimes become vitamin B12 deficient because Crohn's does a wicked inflammation of the entire thickness of the intestine. Ulcerative colitis only hits the very first layer, only the mucosal layer. Crohn's goes all the way through, and it rips up your kabam receptors, and you can't absorb B12. Bile salts, which we might get to, I'm not sure if we'll get that far. Bile salts also pass through, or kind of pass through to the large intestine, and if they get irritated, they won't reabsorb water. And we'll look at that more here in a second. Vitamin B12, yep, we're going to get into the weeds here on that in a second. But again, remember, that's the only place vitamin B12 and intrinsic factor are absorbed and get into the bloodstream. Would vitamin B12, you take some vitamin B12 pills, would that get hooked up to the kabam receptor? No. Vitamin B12, about 1% of pure vitamin B12 gets absorbed. That's not enough to sustain life if you have a vitamin B12 deficiency. So it's taking vitamin B12 is not really, doesn't really do that much. It can help if you're vitamin B12 deficient and you're borderline, you can take vitamin B12 and stay away from the shots maybe for about 5 years. But as the condition progresses, it's not going to do it. You're going to have to take the vitamin B12 injections, which work great. Question? That was the question. Okay. So vitamin B12 intrinsic factor, the only place it can be reabsorbed is the distal ileum, and not even the distal ileum. It's like the last 12 inches. It's not even very much of it. So if something is messed up in that area, if you lost that, or you lost your mutation kabam receptor, so you can't reabsorb it, you have a condition called vitamin B12 deficiency. If you have a vitamin B12 deficiency, you're going to have an anemia called megaloblastic anemia. I guarantee I'm asking you a question on the test with these 3 things right here. I'll tell you right now. So vitamin B12 deficiency falls under the category of megaloblastic anemia. Actually, there's one other one. Is it vitamin B9? There's another folic acid. No. Is it B9? Yeah, I think that also can create megaloblastic anemia, but not, the symptoms won't be as bad. You need vitamin B12. We talked about myelin. You need it to replace the myelin on your nerves, the ones, especially the ones that carry pain. And so if you don't have B12, you lose your myelin and your nerves are short-circuited and you're always in pain. But you also need vitamin B12 to build all of your blood cells, your white blood cells, your platelets, and your red blood cells. need vitamin B12, especially your red blood cells. So if you have a vitamin B12 deficiency, you don't build functioning red blood cells, and you get the classic signs of anemia, which are no power, get out of breath easily because red blood cells carry oxygen. They get rid of carbon dioxide as well with red blood cells, so you can develop a abnormally high level of carbon dioxide. You just don't feel good, as with many anemias. And megaloblastic anemia is under the giant heading of macrocytic anemia. So macrocytic anemia, and notice these words mean big, megalo, macro, those are like big. What does that mean? That means that a lot of red blood cells that don't work, they get ejected into the blood, and those precursors of normally functioning red blood cells are huge. They're immature red blood cells, and they're much bigger than like your normal red blood cell. So they call it megaloblastic anemia, meaning you got big blood cells. Blastic meaning they're the precursors of the real deal. So, and that's where macrocytic. There's also microcytic anemia. So that the blood pathologies, I don't know who teaches that, but I'm sure you'll get the different blood pathologies. All right, so here's a condensed version. I do have YouTube videos on the full version of this. It's about 20 slides long. Thought we'd just kind of water it down a little bit and just give you the facts of this thing. So here's the vitamin B12 absorption study. We won't go all the way, we'll just take it into the distal ileum. So you chew up, so there's vitamin B12 in food, a piece of liver, egg whites, whatever the food be. The vitamin B12 is bind to different types of protein. Because remember I said vitamin B12 is really a wimpy molecule. It does not like to be alone. So you chew it up and swallow it, and the food binding protein in B12, they go down your stomach, kerplunk into the stomach. So there's the food binding protein, I guess is P, and cobalamin, that's vitamin B12. There's also another protein. It's called heptocorin that is produced by your salivary glands that is also mixed in, but it's not bound to yet, but it is mixed in. That also goes down your esophagus, kerplunk, there it is floating around there. And what happens next? Turns out that the pepsin is the only thing that will do this. The pepsin can break the food binding protein off of the vitamin B12. And now vitamin B12 is naked and afraid. It's scared. There's nobody with it. But that's okay because now you have heptocorin. I think it's called transcobalamin 1 is an AKA for that. Transcobalamin 1, but we won't worry about that. Where'd it go? There it is. Heptocorin is right there, and it immediately hooks up with the vitamin B12. So vitamin B12 is safe. It's got a protector. Everything is cool. Now we got intrinsic factor being created by the parietal cells. So intrinsic factors in the stomach with the heptocorin and with the vitamin B12, but it does not bind in the stomach. So all this stuff is kicked out of the stomach into the duodenum, and now something else happens. So we get some enzymes from the pancreas, some proteolytic enzymes, like trypsin, chymotrypsin, and they rip the heptocorin right off vitamin B12. So vitamin B12 is now naked and afraid again. So there it is. So there's the protein, there's the enzymes, proteolytic enzymes. It acted, it broke apart the heptocorin, and intrinsic factor is naked and afraid again, but don't fear because intrinsic factor is here. Intrinsic factor grabs it and binds to it very strongly, and nothing's going to mess with that normally. And we talk about in pathology, there's some autoimmune conditions that can mess the cycle up, but we won't get that far into this. So now intrinsic factor and B12 will go through the entire intestinal tract until it comes all the way down here to the distal ileum. And there is a distal ileum cell, enterocyte, you can call that, ileocyte, you can call that. But there is the CBAM receptor, or the cubolin receptor, that hooks up the intrinsic factor B12 complex, and that is taken inside the cell, and B12 is broken loose again and kicked out the bottom of the cell. And there's another one, I think that's all the farther I want you to know. So that's good enough. Just know that it hooks up to somebody, it hooks up to transcobalamin 2 mainly, which is also secreted by this enterocyte. And it hooks up again and gets in the bloodstream, goes to the liver, stored in the liver, and goes to the bone marrow. It goes all over the body for various things. So that's the story. And I'm sure they'll get into the weeds on that when you get into nutrition, but that'll be a good start for you, I think. Everybody good with that? Pretty straightforward story. Question? What's that? When it comes out the bottom, transcobalamin 2. So heptocorin, aka is transcobalamin 1, and then transcobalamin 2 is spit out the bottom of the enterocyte, and they hook up together. It's absorbed into the venous system, and it's taken into the liver and circulated. I'm not going to remember. If it's not on the slide here, you don't have to worry about it. Everybody good with that? As good as possible? All right, why do we care about vitamin B12? We've already said this. Without vitamin B12, you lose myelin, especially on the big nerves that carry the sensation of certain types of pain. And without the myelin, they start spontaneously discharging, and you start getting pain flaring up all over your body in weird ways. Patient will go online and say, oh, I must have sciatica, or I have a pinched nerve somewhere. And a lot of times they do, but if you see a patient come in and they have pain in both legs, always ask them about their hands and their arms. If they have pain in their arms and hands as well, that's something else going on. You know what one of the earliest things is, unfortunately, that does that? Multiple sclerosis can start like that. So the usual suspects: vitamin B12 deficiency, multiple sclerosis, Guillain-Barré. Another thing that can do this that you got to check for, Lyme's disease can do the same thing, can demyelinate some of these pain fibers. So I'm sure you'll get that somewhere else, but you're going to use that forever when you see patients with extremity pain. Yep, everything I said. And when pain, you remember what we call pain that radiates down a strip? Is it radiculopathy or radicular pain? Radicular pain, which may indicate radiculopathy, is a positive loss of motor reflexes or positive neurological finding. But if they have pain in all the different dermatomes, that's not radicular pain. That's called neuropathic pain. And that's the type of pain that multiple sclerosis will usually cause, or Guillain-Barré, or all these other things. They'll get like a weird pain that's not really in a dermatome, or it shifts around, especially when they say, I used to have it on this side and it shifted over to that side. They're not processing pain correctly. You got a tough patient on your hands. What time are we out of here? 10 till? Okay. Is it 11:30? Oh, it is? Okay, let's see where we can. Let me see where we can stop. Let's stop here. We're just starting the story. We'll stop here in the histology story. Right? No? Because we're out of time? Okay. You don't want to go over? Make sure you don't get behind. Try to study those hard. That stomach physiology. Don't try to wait till the last minute. You'll be in trouble with that. Email me questions if you have questions.